Very good afternoon to everybody who has joined us for this session. On behalf of KIMS Cuddles team, we warmly welcome you for this session, which will be on high frequency ventilation. And this is Dr. Aparna, Clinical Director Neonatology at KIMS Cuddles, Kondapur. I hope you are all able to see the slides as well as hear the audio clearly. Kindly indicate in the chat box if you are unable to do so. So, as you all know, high-frequency ventilation refers to a group of ventilatory techniques that utilize supraphysiological rates of ventilation with the smallest of tidal volumes possible. So, this was initiated with the intent of reducing lung injury despite delivering high mean airway pressures. So, the idea of high-frequency ventilation is to be able to deliver a high mean airway pressure with the least possible chance of lung injury, and to reduce the risk of air leak and chronic lung disease, or to prevent the progression of existing air leak. The other advantage of high frequency ventilation is that it helps us to independently titrate or regulate oxygenation and ventilation, unlike conventional ventilation, where a change in one parameter, for example, PIP, can influence the risk of the carbon dioxide washout as well as improving oxygenation. So, for example, if you're using conventional ventilation at a peak pressure of 20 by PEEP of 6 and the baby develops CO2 retention with appropriate oxygenation, you may want to actually increase the peak pressure, the PIP, to around say 22 in an effort to improve CO2 elimination. But this change will also affect the mean airway pressure. Hence, you may also find an undesirable increase in oxygenation, which may not be wanted at that point of time. Whereas in high-frequency ventilation, to a large extent, we are able to independently control oxygenation and carbon dioxide elimination. For example, MAP, mean airway pressure, or PEEP, as referred to in some ventilators, and FiO2 are the two parameters that help us to control oxygenation, whereas amplitude or delta P as well as frequency help us to control the CO2 elimination. So the question arises, why do we use small tidal volumes in high frequency ventilation, and how does this work despite using small tidal volumes? Very often the tidal volumes used in high frequency ventilation may be smaller than the anatomical dead space. So we all know that in a typical normal newborn, the tidal volumes range between 5 to 8 ml per kg. Up to 1.5 ml per kg may only be accounted for by the anatomical dead space. So when we use high frequency ventilation, we may be operating at very small tidal volumes of around even 1 ml per kg. This may be even smaller than the anatomical dead space. So the question arises, how does high frequency ventilation effectively result in ventilation at all? And we all know that alveolar ventilation is the product of tidal volume into respiratory rate. And to be more precise, in alveolar ventilation, we reduce the dead space volume from the tidal volume. So it's tidal volume minus dead space volume multiplied by the rate. So if 5 ml per kg is the total tidal volume, at 1.5 ml per kg is the dead space volume, then for calculating the alveolar minute ventilation, we take 5 minus 1.5, that is 3.5 ml per kg multiplied by the rate. So, if the tidal volume in high frequency is lesser than the anatomical dead space, the question arises, how does it result in effective ventilation? And we shall be discussing a little bit about this when we discuss the various mechanisms of high frequency ventilation. So, why did people think of using very small tidal volumes for achieving ventilation in newborns? So, it has been seen that by using small volumes for progressive displacement of ventilatory gases that is used for achieving gas exchange with high frequency ventilation, this may help us to achieve or to be able to operate at higher PEEP. So it helps us to reduce the side effects or reduce ventilator-induced barotrauma or volutrauma that is associated with the use of higher airway pressures. And that is one of the main advantages of using small tidal volumes in high-frequency oscillation. So in other words, it helps us to be able to deliver higher mean airway pressures without causing much lung trauma. Often this is referred to as lung protective strategy or open lung strategy. So the physiological basis or origin of high frequency ventilation dated back to around 1915, when a researcher called Henderson, who was intrigued by the rapid panting pattern, shallow and rapid panting pattern of dogs, wondered how the dog could actually achieve effective gas exchange. That is, it did not become hypoxic or hypercapnic despite having a very small amplitude and rapid breaths. This thought actually gave way to an experiment that ultimately helped us to discover something called flow streaming, which paved the principle for high frequency ventilation. So it was found that when one blows smoke into a hollow glass tube, a cylindrical glass tube in one quick puff, so the person who blew tobacco smoke into this tube initially found that it shot down the tube in a long spike. So this gas actually effectively did not disperse or mix with the rest of the gas which was present within the tube. However, when the other end of the hollow tube was actually blocked or the gas flow was stopped, the diffusion of the tobacco smoke happened within the tube, and this was called as flow streaming. So until this happened, the flow seemed to shoot down in a conical pattern across the gas tube. So this accounts for one of the principles. Although we use small tidal volumes in high frequency ventilation, the effect of the ventilation that is driven by every breath is actually dispersed in a conical fashion, and it traverses a significant distance along the airway. And whenever the expiration process begins, or when the flow is stopped, the inspiratory flow of gases is stopped, the molecules of fresh gas actually disperse effectively within the tube, which is the windpipe or the airway. So this was true even when the gas was streamed across a tube which has a central bulb-like swelling in the center. Even then, when one blew tobacco puff across the tube, there was very little contamination with the clear air or clean air surrounding the stream. Again, there was complete dispersion when there was cessation of flow at the other end of the tube. So this flow streaming kind of is the important principle behind high frequency ventilation. So there are multiple devices now that help us to use high frequency ventilation in clinical use. This ranges from regular hybrid ventilators such as SLE 6000 or Draeger ventilator, which help us to achieve both conventional ventilation as well as high frequency ventilation. Whereas we have some exclusive high frequency oscillators like the SensorMedics oscillator, which are effective for delivering only high frequency ventilation. So we shall be next discussing about three primary modes of high frequency ventilation, which are the following: high frequency positive pressure ventilation, high frequency jet ventilation, and of course high frequency oscillatory ventilation. These are the three commonly known clinical terminologies that are used, or different types of high frequency ventilation. So high frequency positive pressure ventilation is, in other words, a rapid form of conventional ventilation, wherein as against regular conventional ventilation, where the typical respiratory rate that is used is something between 30 to 60 breaths per minute, normally in neonatal ventilation. Here we operate at higher rates. The rates range between 60 to 150 breaths per minute. High frequency positive pressure ventilation manages this by using small internal compressible volume. So the tubings that are used are such tubings that occupy small internal compressible volume, and it operates at high gas flow rates, and wherein it is efficient at small tidal volumes. So some of the ventilators that can be used for doing high frequency positive pressure ventilation include the following. So the Draeger Babylock 8000 is one of the commonly used modes of high frequency ventilation. So this is a kind of exaggerated version of a conventional ventilation which operates at much rapid rates against what is normally used in conventional SIMV mode of ventilation. These are some other examples. Moving on now to the second type of high frequency ventilation, which is high frequency oscillation. So this is a picture of the SensorMedics device, which is an exclusive high frequency oscillator. So this ventilator has a specific membrane or a diaphragm that oscillates to and fro. in order to generate high frequency oscillation breaths. And this is a process wherein expiration is also an active process. So by the backward movement of the diaphragm, it creates a negative pressure which actually pulls out gases from the newborn's lungs, which is in contrast to regular conventional modes of ventilation, where expiration is typically facilitated by passive elastic recoil of the muscles. The third form of high frequency ventilation is the high frequency jet ventilation. So this is a type of ventilation where over and above the normal endotracheal tube connector, we have a specially designed endotracheal tube connector which has three ways. So one is connected to the proximal airway of the baby's ventilatory circuit. The second one is used as a pressure manometer, and the third one is used for injecting high frequency jets of gas, which help us to deliver high frequency jet ventilation. This is available with a ventilator called as Bunnell Life Pulse, and few such ventilators are now available in India. So this is another example of a high frequency flow interrupter. So moving on to the differences between these three modes of high frequency ventilation. So high frequency oscillation that is most commonly used and is available with Sensormedic's ventilator and is also available with few hybrid modes of ventilators such as the Sophie Stephanie or SLE 6000. Here HFOV is generated by means of a piston or maybe generated also by an expiratory valve that can be seen in the regular ventilator that moves back and forth multiple times. The inspiration to expiration ratio is typically 1:1 to 1:2, and the optimal frequency ranges between 8 to 15 hertz. So 1 hertz refers to 1 breath per second or 60 breaths per minute. So 10 hertz refers to 600 breaths per minute, and 15 hertz will refer to 900 oscillations or breaths per minute. So the typical optimal frequency is between 8 to 15 hertz. Video runs. The ability to superimpose a sigh breath is applicable with conventional ventilators like the Babylog ventilator and the SLE 6000, whereas this is not possible when we use a pure oscillator like Sensormedics. With high frequency jet ventilator, we know that the mechanism is by the use of a pinch valve that superimposes high velocity jets of gas over and above the conventional breaths. The typical I to E ratio that is applicable with high frequency jet ventilator ranges from 1:4 to 1:8, and the optimal frequency is between 5 to 10 hertz. This refers to a breath rate of 300 to 600 breaths per minute. With high frequency positive pressure ventilation, the typical solenoid valve is the mechanism for generation of high frequency ventilation with IE ratio of 1:3 to 1:6. The optimal operating frequency in HFPPV is 1:2.5 hertz, which is 60 to 150 breaths per minute, whereas for high frequency flow interrupter, this ranges between 8 to 12 hertz.
YouTube was
video importantly. Okay, so we'll now discuss about the different mechanisms of high frequency oscillation ventilation. As you can see in the picture, we know that while using HFOV, the tidal volumes that are used are lesser than the anatomical dead space, and we are operating at supraphysiological rates. So one of the very easy to understand and plausible mechanisms is that there is to some extent direct alveolar ventilation of the proximally placed alveoli that are placed closer to the proximal trachea. So until this point, the regular gas flow with high frequency oscillation generally occurs, and to a large extent, the direct ventilation of the proximally placed alveoli occurs, and this contributes to gas exchange. The second next important mechanism of HFOV is something called pendulift. In pendulift, there is gas flow not only from the airway to the alveoli, but between alveoli because of the inhomogeneous time constants. So imagine you have two neighboring alveoli, of which one has a small internal radius and thereby a shorter time constant, whereas another alveoli which is sort of having a larger time constant, which could be because of the decrease in the increase in the resistance of the alveolar septation. So because of the inhomogeneous or different time constants of these two neighboring alveoli, there is going to be concurrent gas flow between the alveoli in addition to the gas flow from the proximal airway to the alveoli. So it has been found that the net ventilation to all the alveoli in high frequency ventilation is greater than the gas flow that is achieved from the ventilator to the alveoli. So this kind of accounts for some pen-to-left related ventilation amongst the neighboring alveoli because of the inhomogeneous time constants. So during inspiration, the alveoli with the shorter time constant tends to get fully inflated earlier. Hence, there will be some net gas flow from the alveolus of shorter time constant to that of the longer time constant. Whereas during expiration, because of the expiratory time constant also being longer, the shorter alveoli would actually rapidly empty also. So this will again result in gas flow in the reverse direction from the alveoli of longer time constant to the one with shorter time constant. There is also another important mechanism called Taylor's dispersion. So there is to a large degree asymmetry in the velocity profiles during inspiration and expiration. So you can see that during inspiration, the gas flows in a conical fashion with the gas molecules in the center of the airway reaching the largest distance, whereas the gas molecules which are situated closer to the sides of the airway achieving the least possible distance. So this results in a conical or a tapering shape of the velocity of the inspiratory gas flow. Whereas when it comes to expiratory gas flow, it occurs in a block-like fashion. So it is fairly symmetrical when it comes to expiratory gas flow. So with every breath, the length of the tube or the tip of this cone keeps becoming longer and longer during high frequency ventilation. And whenever the gas flow stops, there is complete dispersion of the gas molecules. So this results in significant gas exchange. So these are some of the important mechanisms of gas exchange, and this is further facilitated by the convectional and radial convection currents of the gas molecules, as well as Brownian dispersion or Brownian movement of the random movement of the gas molecules, and to some extent, the cardiac contractions also contribute to gas exchange during high frequency ventilation. An interesting concept here is the relationship of high frequency ventilation amplitude or the tidal volumes to the CO2 elimination. So we know that in conventional ventilation, carbon dioxide elimination is directly proportional to the product of the respiratory rate and the tidal volume. When it comes to high frequency ventilation, the carbon dioxide removal happens to be directly proportional to the product of the respiratory rate into the square of the tidal volume. So to understand this concept better, let us see what happens at various operating frequencies of high frequency ventilation. So typically, we just saw a little while ago that when we use high frequency oscillatory ventilation, we tend to operate at frequencies between 8 Hz to 15 Hz. And this corresponds to 1 Hz being equal to 60 seconds. This will correspond to 480 to 900 breaths per minute. So we can see that as the frequency increases, so that is towards the right side of this graph, the tidal volume keeps declining more and more. So the carbon dioxide washout elimination in high frequency ventilation tends to be directly proportional to the product of tidal volume square multiplied by the respiratory rate. So even if we keep increasing the frequency, particularly beyond 10 to 12 Hz, because of the rapid decline in the operating tidal volume, the effect on CO2 elimination can actually be counterproductive. This explains the inverse relationship between high frequency the frequency and CO2 elimination in high frequency ventilation, which is in contrast to conventional ventilation. In conventional ventilation, as we keep increasing the rate, the CO2 elimination keeps getting better and better. Whereas in high frequency ventilation, when we increase the rate, Because of the much more significant impact of the tidal volume on CO2 elimination tends to become poorer, and this is the reason that higher frequencies result in CO2 retention in high frequency ventilation. So we will now move on to oxygenation in high frequency ventilation. Oxygenation efficiency depends upon optimizing the So when we talk about open lung strategy, this is a strategy of using high volume, which is useful in severe parenchymal problems like respiratory distress syndrome. When we switch from conventional ventilation to high frequency ventilation, it is important to use a MAP which is 10 to 20% higher than on conventional ventilation to achieve open lung strategy, and increase the MAP in steps of 1 to 3 centimeters of water increments until oxygenation improves. We are supposed to have reached the optimal MAP or optimal P if you are able to manage to titrate FiO2 to up to 30 to 40%. And once the lung improves, then one starts weaning the MAP slowly. So weaning in FiO2 should take precedence over weaning of MAP. Whereas if there is air leak, then one may go slow in weaning FiO2 as well. When we switch from conventional to high frequency ventilation in cases of established air leak or high risk of air leak, such as in a baby with pulmonary hypoplasia, it is important to use the same MAP as in conventional ventilation, or you may also want to reduce the MAP by around 1 to 2 centimeters of water. So there are 3 types of indications of initiation of high frequency ventilation. I shall not be touching upon the prophylactic usage of high frequency ventilation because this is not something that is recommended based on scientific evidence. We will only talk about the early rescue and late rescue initiation of high frequency ventilation. So where all do you switch to high frequency ventilation early in the course of the disease? In babies with established pulmonary air leak syndromes like pulmonary interstitial emphysema, so preterm babies with PIE, or preterm babies or term babies with bronchopleural fistula or pneumothorax, or in conditions where there is high risk of air leak such as pulmonary hypoplasia, or in conditions where there is severe restriction of chest wall movement such as necrotizing enterocolitis, high drops, or in post-op cases such as gastroschisis and omphalocele, where due to anatomical problems there can be a limitation in chest wall movement, one must have a low threshold to switch from conventional to high frequency ventilation. Late initiation of high frequency ventilation is indicated in conditions where the parenchymal involvement may be severe, such as severe cases of respiratory distress syndrome or severe hyaline membrane disease, severe congenital pneumonia or severe persistent pulmonary hypertension of newborn, and severe meconium aspiration syndrome. So remember that when it comes to MAP, We generally start with 1 to 3 centimeters higher pressure than the MAP that was prevailing on conventional ventilation, because MAP is what controls the VQ mismatch, the ventilation perfusion mismatch, and thereby oxygenation. Begin with a frequency typically between 8 to 12 hertz. The smaller the baby, the more will be the initial frequency. So we could begin in a preterm baby with a frequency of 12 to 15 hertz, whereas in a term baby, we begin with a frequency of 8 to 10 hertz. And we know that 1 hertz corresponds to a rate of 60 cycles per minute or 1 cycle per second. Also begin with an initial inspiratory time of 33%. This can be increased up to 40% depending upon the oxygenation. Now, the amplitude that is optimal or recommended is the amplitude that is necessary to generate sufficient wiggles or chest movements. This can be assessed on the anteroposterior dimension, and this must be present from the until the baby's umbilicus, and this is the main determinant for carbon dioxide elevation. So the amplitude and frequency drive the CO2 elimination. Alveolar recruitment is important to achieve good oxygenation. Thereby, MAP is very important to achieve the open lung strategy. Higher initial MAP may be required during recruitment. Though increasing MAP is beneficial for improving oxygenation, it also increases the risk of barotrauma, and this strategy must be used with caution. Higher MAP also interferes with the cardiac output by interfering with the venous return. So in most of the lung diseases, in term babies, it may be ideal to begin with a MAP of something around 12 to 14 based on the underlying condition. So when you switch from the conventional ventilation, like we already discussed, we begin with a MAP which is maybe the same or maybe slightly lesser than the MAP on conventional ventilation if the baby has pneumothorax, pulmonary hypoplasia, or CVH, where there is associated pulmonary hypoplasia. Whereas in severe HMD, pneumonia, and PPHN, we begin with a MAP which is greater than the MAP on conventional. If there is hypotension or cardiac instability, the MAP can be reduced by 1 to 2 centimeters in order to optimize the venous return and cardiac output, and try to not wean FiO2 until we not wean the MAP until we reach an FiO2 below 40%. One also has to remember that the airway pressure that is delivered at the proximal airway may be different from the airway pressure at the baby's alveolar level. So as you can appreciate in these two graphs, the top two graphs represent high frequency jet ventilation, and the two graphs in the bottom represent high frequency oscillation ventilation. So let's look at HFOV because that's what we all commonly use. So as you move from the proximal airway to the distal airway, there is a the progressive the peak tends to increase and the MAP remains fixed, but you can see how the amplitude tends to progressively attenuate in high frequency oscillation ventilation. So the amplitude tends to get dampened in the distal airway, whereas peak may slightly increase. MAP almost remains the same with regards to high frequency oscillation ventilation, but with high frequency jet ventilation, the MAP tends to decline in the distal airway or alveoli. So we have discussed about the clinical application of MAP in high frequency ventilation. Now moving on next to amplitude. Increases in amplitude or the delta pressure help in washing out carbon dioxide or help in CO2 elimination. Amplitude is what is dependent on the forward and backward movement of the piston in the ventilator. So this movement drives the gases into the baby during inspiration and kind of pulls the gases out of the baby during expiration. And we have discussed this is why expiration is considered to be active in high frequency oscillatory ventilation. Low compliance as well as high resistance decreases the amplitude that is effectively delivered. So what are the implications for practice when it comes to amplitude or delta P? The rule of the thumb is we begin with an amplitude that is roughly equal to twice the mean airway pressure on high frequency ventilation. So if one begins with high frequency MAP of say 15, the typical delta P or amplitude must be around 30. Set the initial amplitude between 20 to 40% and adjust based on the wiggles, and we're monitoring PaCO2. So one must clinically assess the wiggles during the application of high frequency oscillation. Greater the wiggles, more effective is the delta P. Likewise, greater is the CO2 washout. That indicates that the baby is getting sufficient amplitude, and if CO2 washout results in hypocarbia, then one may start coming down on the amplitude. On the other hand, if one is seeing high carbon dioxide levels or CO2 retention, then we increase the amplitude. Now, despite setting the right amplitude, we may sometimes see poorly noticeable wiggles, and this can be due to other technical aspects like a small diameter of endotracheal tube or a large length of the ET tube because of an uncut endotracheal tube, and this can increase the airway resistance. The wiggles may also be poorly noticeable if there is tube block, chest wall rigidity like in high drops, and with the use of conventional style circuits with lot of circuit-related dead space losses. For any given amplitude, improvement in complaints in the baby's lung condition or respiratory mechanics, as it gets better and better, we will notice increase in the wiggle, and hence amplitude should be progressively reduced. Otherwise, we'll end up in significant CO2 washout. Coming to the frequency, the optimal frequency is actually decided by the baby's size, or what we call as resonating frequency of the baby. So for a term baby, as we discussed, we tend to start with a frequency which is on the lower end, like 8 to 10 hertz. And for a preterm baby, we may start with a frequency which is 12 or 15 hertz, because this corresponds with the resonating frequency of the baby. Likewise, based on the disease physiology, shorter the time constant, like in RBS, one begins with a high frequency, whereas longer the time constant, we begin with, larger the time constant, we begin with a smaller frequency. So optimal frequency produces the best possible alveolar ventilation with the available delta P and tidal volume, and does not result in gas trapping. So we must be aware that if we use very high frequency, we may be kind of compromising on the delta P and thereby the tidal volume, and this results in CO2 retention with high frequency ventilation. There may also be gas trapping with excessively shortened expiratory times. As complaints improves, the frequency should be reduced, and as resistance improves or as the resistance decreases, the frequency must be increased. In the presence of a fixed IE ratio, so typically if the inspiratory time is 33% or at an IE ratio of around 1:2, as the frequency is reduced, the I time decreases, and therefore the tidal volume delivered also can be decreased. So as and when the frequency increases, one must remember that the tidal volume is effectively reduces, and hence this is responsible for CO2 retention. Most use 10 hertz as the starting point of frequency, which is roughly equal to 10 times of the rate used in conventional ventilation. So with the assumption that we may have reached a rate of around 60 breaths per minute on typical SIMV, by the time we take a decision to switch to high frequency ventilation, 10 times of 60 breaths per minute is 600 breaths per minute, and this is the same as 10 hertz. So what do we do if PaCO2 on high frequency starts dropping, and if you are already on a low amplitude? Of course, the first change we start doing when there is CO2 washout is to reduce the amplitude. But when we have already reached an amplitude that is below 20 centimeters of water, which is traditionally considered as low amplitude, then we may start having to think of increasing the frequency. So we have discussed about various settings. We started with MAC. We discussed about open lung strategy. Then we discussed about amplitude, about how we decide the initial amplitude, how we increase or decrease it based on the clinical parameters and the blood gas, and finally about frequency. Now we'll discuss some of the challenges or complications with high frequency ventilation. One of the commonest side effects is the creation of something called as choke points. So these are points in the airway where, because of the reduced tensile strength or structural strength within the airway of the newborn, there may be areas where the airway could have completely collapsed, which results in gas trapping. So this is because gas is actively pulled out of the baby's alveoli during expiration. So this results in progressive air trapping, and this can be recognized by the fact that if one reduces the MAP in a baby who has developed choke points, this can only make the gas trapping worse. Usually, we expect that once we start reducing or weaning MAP, the gas trapping improves. But when we are dealing with choke points, gas trapping actually starts getting better when we increase the MAP, and this increase in MAP will result in opening up of the choke points, and hence it facilitates expiration of gas. The other challenges with high frequency ventilation include inadvertent hypocarbia because of CO2 washout, the high flow velocity of the gas that is being used can result in necrotizing tracheobronchitis. Increased requirement of tracheal suctioning may be one of the problems. So with high frequency ventilation, the nurses need to monitor more often for tubal obstruction. And when high mean airway pressures are used, although this may be desirable for the parenchymal disease that we are treating, it may result in impedance to the venous return. Important nursing care considerations with high frequency ventilation are the following. Very important to avoid disconnections in the circuit because this can result in break of the open lung strategy and this can result in atelectasis of the baby's lungs. Suctioning should be used judiciously. We understand that there can be an increase in the need for suctioning, and wherever possible and wherever the unit is comfortable with closed loop suctioning, this could be considered. The vital signs of the newborn, especially the heart rate, the blood pressure, signs of peripheral perfusion, the urine output, and periodic monitoring of the blood gas, particularly for carbon dioxide washout, are very important. A chest X-ray may be initially done after 1 hour of initiating high frequency ventilation. And normally on the X-ray, we expect around 8 to 9 posterior intercostal spaces. Humidification is very, very important in any form of ventilation, but more so with high frequency ventilation, particularly with the high gas flow that is used, the flow rate that is used, in order to prevent the complication of necrotizing tracheobronchitis, particularly with high frequency jet ventilation, where this is one of the commonest problems. And one should clinically monitor the baby's oxygenation using saturation monitoring, pulse oximetry monitoring, and also clinical assessment of the chest wiggles. So wiggles must be normally perceptible until the baby is umbilicus, and the amplitude of the wiggles can also be monitored from the anteroposterior aspect of the baby. When it comes finally to the evidence on high frequency ventilation, this is a relatively old systematic review. So this did show that the elective use of high frequency ventilation when compared to conventional ventilation did not result in improvement of any of the major morbidities, including death before discharge, the incidence of bronchopulmonary dysplasia, the incidence of severe rates of intraventricular hemorrhage or cystic periventricular leukomalacia. There was a trend towards a reduction in ROP of stage 2 or more, and there was also a significant reduction in PDA requiring surgery. Possibly these were related to the use of open lung strategy and limiting the use of FiO2 with ventilation. So to summarize, before we move on to the bedside, the carry-home points are the following. Both conventional ventilation and rescue high-frequency ventilation are reasonable options. Elective use of high-frequency ventilation is not really supported by any scientific evidence. So whenever there is failure of conventional ventilation, we think of high-frequency. While using high-frequency ventilation, one must be aware of open lung strategy. Humidification is very, very important, and so is the need for close nursing care and monitoring for potential complications like necrotizing bronchitis, as well as the monitoring for regular need for suctioning. One must remember that there is a dependence of tidal volume on frequency, hence increase in frequency can paradoxically result in CO2 retention in high frequency ventilation, and always monitor for inadvertent hypocarbia. The use of high frequency ventilation, despite helping us achieve higher mean airway pressures without causing more lung injury, still has not been found to reduce the incidence of bronchopulmonary dysplasia. So we will now move on to the baby's bedside for a brief demonstration. So I hope that the video is clear. So we will discuss some of the salient clinical aspects. So while we initiate high frequency ventilation, so the first aspect is when do we start or when do we consider high frequency? So whenever you have failure of conventional ventilation, which is defined as the need for a mean airway pressure of more than 14 to 15 in a term baby, and if we are needing a mean airway pressure of more than 12 in a preterm baby, despite which we are not able to achieve oxygenation or CO2 elimination. So if there is hypoxia or decrease in saturations, despite 100% FiO2, or if the PaO2 when measured in the blood gas is below 50 millimeters of mercury, or if you're seeing CO2 elimination, so CO2 more than 55 to 60 millimeters of mercury with a pH below 7.25. If any of this is evidenced as a failure of optimal gas exchange despite maximum settings on conventional ventilation, so MAP more than 12 in preterm and MAP more than 14 to 15 in a preterm, and failure to oxygenate despite using maximal FiO2. Or if on conventional ventilation, irrespective of the settings, we start seeing air leak. So this could be a pulmonary interstitial emphysema in a preterm or a pneumothorax in a term baby. If any of this is seen, that indicates failure of conventional ventilation. And we have discussed already that this is the situation where we use HFOV as a rescue valve. So first and foremost, use the circuit that is specific or designed for the ventilator. Using adult circuit or pediatric circuit will result in lot of circuit volume losses, and we must remember that we are dealing with physiological tidal volume. So already the tidal volumes at which we are operating are around 0.5 to 1 ml per kg. So further, if there are circuit losses in the volume, then this is going to make it ineffective. So use the small compressible, the volumes, the small compressible volumes are possible with the specially designed circuits for high frequency. So once you connect the circuit, make sure that you have switched on humidification. So since we have just switched it on, the temperature is rising now. The water level should be always filled until the black line. The temperature, once it it attains the optimal temperature, should be at 37 degrees Celsius. And one should not see any humidification along the circuit, along the inspiratory circuit. You may see condensation in the expiratory circuit. The proximal airway pressure line should be connected even with high frequency ventilation, because we will need this to monitor the delivered pressure. There is an option of using high frequency with volume guarantee in Draeger ventilators, and this is also an option, in which case we will also be connecting the flow sensor here. So this is the knob for connecting the flow sensor. Now, once you start, you will be given the option of selecting either high frequency ventilation or high frequency with CMV. If it is added with CMV, we can also set a few sigh breaths. So once you choose the option of CMV, the ventilator will ask you how many sigh breaths you want to deliver. Typically, we keep around 6 to 10 sigh breaths until we have reached the optimal lung recruitment. So sigh breaths are, as you can see here, there will be intermittent breaths of a designated PIP. Of course, you can increase the PIP required in the sigh breaths. So you may use, say, pressures of 15 or 20 above the peak, like you can see here. These are all breaths with high peak inspiratory pressure with the idea of recruiting the lung. So sigh breaths may be used until we have reached sufficient functional residual capacity. Now, once we have reached sufficient alveolar recruitment, you can always choose to reduce the number of sigh breaths, or you can completely move to high frequency alone, where you do not have to add additional sigh breaths. So here there is no concept of sigh breaths. Automatically, I'll also reduce this to 0. We can completely switch this off. So now it will only function as high frequency ventilation over CPAP. So it gives a constant P over which you see oscillations that of pressure, which will be determined by our amplitude. So when it comes to the primary parameters, we are going to set MAP, which is the same as P, and FiO2. These two parameters are concerned directly with oxygenation. The other two important parameters are delta P and the frequency. So I told you that when we move from conventional ventilation due to severe parenchymal lung disease like pneumonia, RDS, or severe PPHN, we will choose a map which is 2 to 3 centimeters higher than the map on conventional ventilation. So for example, let's assume this term baby, we are switching from a map of 14 on conventional. We will begin with maybe 16 or 17 of map. Generally, we set the FiO2 at the same FiO2 on conventional ventilation or maybe 20 to 30% higher, because usually we are switching to high frequency itself because there could be hypoxic respiratory failure. So here there is constant alarm. Now the next parameter which is still not set here is the delta P. So where would we set the delta P? So as a rule of thumb, I told you that we begin with a delta P which is close to around twice of the map. So if you're beginning with a map of 15, you could begin with a delta P of 30. Now we have begun with 17. Let's start with a delta P of 34. Okay, so once you start the HFO, you can see that the oscillations or wiggles can be ascertained from the baby's chest, and usually we look for wiggles until the umbilicus. The other parameter that we would be setting is the frequency, which is decided by 2 parameters. One is the patient size, and second is the underlying time constant of the disease that we are dealing with. So smaller the baby, more will be the frequency. Shorter the time constant of the disease, like RDS, if we are ventilating with HFV, again, higher will be the frequency. Larger the time constant, lesser will be the frequency. So if you're using HFOV for meconium aspiration syndrome, try to use a frequency which is not very high. You may use 8 to 10 hertz, and usually these would be term babies also. So these are the 4 parameters, and this is how we decide the starting settings. Now, how do we titrate them? For FiO2, we will be looking at the saturations continuously, and we target 91 to 95%. And intermittently or periodically, we will be looking at the PaO2 in the blood gases. When it comes to MAP, the initial parameter, as we discussed, is we allow the baby to reach optimal lung volume as measured by the X-ray of around 8 to 9 posterior intercostal spaces, and as seen clinically by the absence of retractions. And we allow the FiO2 to come down to around 30 to 40%. Do not wean the MAP until you reach an FiO2 of less than 30%, less than 40% at least. What about the other 2 parameters, delta P and frequency? Delta P clinically can be monitored using the chest wiggles. Wiggles must be seen under the baby's umbilicus. Lesser the wiggles, we may have to increase the delta P. While doing this, also try to rule out other causes like endotracheal tube block, poor wiggles because of chest wall rigidity, or using a very small ET tube or an ET tube with a long length or an uncut endotracheal tube, which can contribute to dead space. Despite all these measures, a baby with poor lung compliance will have less chest wiggles. The next parameter is frequency. So frequency, one doesn't generally taper much, but if you are dealing with very significant CO2 washout, despite using a delta P which has already come to below 20, then we may consider increasing the frequency. This is usually the only scenario in which we try to change the frequency. So these are all how we try to taper or titrate the different parameters. Generally, we are ready to wean the baby out of high frequency once we have reached a MAP of below 7 or 8 and a FiO2 below 30 to 40%. And once we have touched delta P below 20%, it means that the baby is reasonably stable, and you can take a call based on the X-rays, the improvement in the primary disease, whether the baby can be weaned from high frequency to conventional ventilation. So the important nursing precautions that are to be taken are to ensure optimal humidification by ruling out any condensation in the inspiratory tubings, and there should be a provision for closed loop suctioning wherever it is feasible, wherever our nurses are comfortable with the technique, because frequency of suction requirement might be more with high frequency when compared to conventional ventilation. So these are all the important aspects in high frequency ventilation. If there are any questions, kindly post in the chat box. And once again, my sincere apologies for the delay in the middle of the session, which was for almost 15 to 20 minutes. Thank you very much for joining us.